Okay, so we're going to talk about using trauma guidelines for performance improvement. And this is a shortened version of the talk I gave as the president of EAST. I talked all about guidelines, and my talk title was EAST Practice Management Guidelines and the Perpetual Quest for Excellence. So if you like this short version, you're welcome to go online. You can go to the EAST website and watch the whole thing on video. You can also go to the Journal of Trauma website and download the paper and read it all as well. So either option is there. This is a half-hour shortened version of what was about an hour-long talk. So we're going to talk about why. First, the why trauma care. We're going to talk about how to use guidelines for trauma care. And we're going to we're going to talk about the methods to evaluate successful implementation. How do you know you've started a guideline, you've brought it to your hospital, and you're actually using it? So first, we're going to start with what is evidence-based medicine? Evidence-based medicine, we know medicine changes so rapidly. There's new papers, journals, books, podcasts, online resources. All of these things are available, and there's so much information, and it's really hard to tell, where do I get good information, number one, and how do I digest all this massive information and find out what I actually need to use to take care of patients. So the idea behind evidence-based medicine is that experts in the field would pull together all of the data and put out some recommendations and put out resources for people to learn. So it developed so that practitioners like us, physicians, nurses, nurse practitioners, whoever, can stay abreast and understand new important changes in the literature. And for busy frontline clinicians, so we don't have to go read every single journal out there, for the patient in front of us, so that we're making good decisions for the patients that we're taking care of. So that's the idea behind evidence-based medicine. So EAST, the Eastern Association of Trauma for the Surgery of Trauma, is a trauma organization. It's mostly US based, although we do have international members. It's young, it's less than 40 years old, of EAST. And he was the one that we really credit with EAST taking on this important topic of guidelines and evidence-based medicine. And he talked about practice management guidelines for trauma care, and he created the committee that would create guidelines for EAST. And I will tell you, EAST is internationally known for our guidelines. A few people mentioned them already. They were shown on some of the slides. It really is a great opportunity, and I'm going to show you what that looks like. So this is where it started in 1994. So how do we know what is a good guideline? So there was actually a request from the Congress in the United States to help develop standards to know if it's a rigorous, trustworthy guideline. And the Congress asked the Institute of Medicine in the United States to help deal with this. So there's actually a document, you can download this book for free from the Institute of Medicine website. And it asks the question of how can we make a trustworthy guideline? And the title of the report is Clinical Practice Guidelines We Can Trust. There are 8 specific standards. I can go over them very briefly. And it tells you, and this is over 10 years old now, and it tells us how we should be creating guidelines. So why? Why should we have guidelines for trauma care? Why can't we let just Dr. Fickey do whatever he feels like, right? When you get whatever care, you know, Dr. Fickey does it one way and Dr. Saeed does it another way. That's not the best thing for patients. We want to reduce inappropriate practice variation. That's what ATLS does. The same way every time. We've taken ATLS, whether in the United States or around the world, same way every time. We speed the transition of evidence into practice. So this is that we're going to take the best evidence in the literature and bring it into the bedside to take care of patients. We're going to improve care, safety, and quality. We're going to reduce disparities. We talked earlier today about differential outcomes for patients based on their race, We know there's differences by sex, insurance, all these other things. Guidelines can help reduce disparities, and it also can cut costs. So it's not that we're going to spend lots of extra money to do this. We're actually going to save money in the long run. So these are the 8 important standards. So a transparent process. You have to understand why we make a recommendation from an organization. We have to talk about conflict of interest. You know, if I'm being paid by a company to talk about something, you need to know. And that's why I told you before, I don't get paid by TAG or Raboa, but we have to be upfront and clear about that. What's the group composition? If we're doing a guideline on spine injury, I can't do that by myself as a trauma surgeon. If I don't do that with orthopedic surgeons and neurosurgeons, why would anybody listen to us? So we do those things, making sure we have the right composition of the group. A systematic review. We have to find all the literature, all the papers on a topic to make sure we look at all the information. We can't just pick the papers that I think are good. We have to give the quality of evidence. How is this high quality evidence, or is this like, it's pretty good? There's different levels of that. We have to be very clear on what a recommendation is, who it's for, what exactly we should do. They need to be actionable. And then it should go through some external review, and then it should be updated. We have some of these guidelines that are, 15 years old. Should you believe something that says, 15-year-ago technology? Probably not. We need to make sure they're updated. So it's important to understand the standards. There's an approach to do this. It's called GRADE, the Grading, Recommendations, Assessment, and Development of Evaluation. It's a mouthful. It's a specific way that organizations have been asked to create guidelines. And these are the groups that use GRADE. There are many that are local in the United States, huge groups, our CDC, our NIH in the United States, but also global. Cochrane Collaboration is global. Obviously, the World Health Organization. There's all these places that are global. And this is the recommendation. 100 organizations have agreed that GRADE is the way to go. So this is the new approach. So we learned about GRADE. We had never done GRADE for our first 20 years at East. And I was the first person at East paid to go and learn about GRADE. We've now sent over 50 East members to go learn about this approach. These are clinical trauma surgeons who want to learn how to help create guidelines. So we now know the approach to do it. We went to classes, now they're online, of course, but you have to learn the technique. Just like you learn a surgical technique, you have to learn this technique to look at research or guideline creation. And then we wrote a paper on how we're going to do it, how we're going to apply GRADE to the trauma situation. Andrew Kerwin was the committee chair before I took over. He wrote this, and he led this group that started our change over into the GRADE methodology. We put out a supplement in 2012, so now it's over 10 years old. It had about a dozen guidelines in our old format, and we dedicated this to Dr. Rhodes, who really was the one who inspired us to do well for patient-centered care, number one, but also evidence-based medicine. So I'm going to show you how to find all these guidelines. They're all freely available to anybody who wants to read them. And we have guidelines on trauma. This is obviously a polytrauma course. We have guidelines on trauma, but East also does emergency or acute care surgery. So emergency gallbladder surgery, biliary surgery, appendicitis, all those other things. So we have guidelines on emergency general surgery. We do surgical critical care. So we have guidelines on nutrition in the ICU, ventilation in the ICU, transfusion, et cetera. And also importantly, we have guidelines and evidence-based reviews on injury prevention. So we have guideline on ski helmets for when people go skiing and things like that. So we have these are the main topics, but we're going to talk about trauma today. So I'm going to tell you how to find them. Who else cares about these guidelines? Clearly, a few people have read a few of these, but there's lots of places that are looking to East and other organizations about guidelines. One is the National Quality Forum. This is a United States-based group that puts out lots of important high-quality papers that help drive national policy. This one is about population-based trauma outcomes. How should we be doing a good job to take care of patients to improve their care overall across the United States? There were many guidelines. Many were pulled in that NQF report. Many were pulled from East, but there's also others. I've mentioned the American College of Surgeons Trauma Quality Improvement Program. We've seen a few mentions of that already, as well as East guidelines. Same thing, you can go online and find this trauma outcomes project for free online. There's also another report. This came from the National Academies of Medicine. Dr. Fickey's like, I know, I read that book, right? So this same thing, you can go online, here's the website, you can read the 500-page book for free. And this is the important thing about improving the national trauma care system. And it really is a way that we need to do better for all of our patients. And the idea is we want to drive to 0 preventable deaths from trauma. And that's the goal. And the idea was this was put together to collaborate between military and civilian so that there's bidirectional learning. Civilians can teach the military, military can teach the civilians, and we all work together. So this book, this report came out and looked at it. This is a picture of the writers of this report. There's many people that are internationally known in the trauma world. This is my mentor when I was a trauma fellow and a resident, Bill Schwab. And then this is Ellen McKenzie. Ellen McKenzie was on that New England Journal paper that I think you showed about the LEAP study. She's a trauma researcher, non-physician, PhD researcher who's dedicated her life to injury research. She's now the dean of our School of Public Health. So it's some people we know. And one of the things that this book talks about is clinical guidelines. It talks about the importance of using them for decision support, putting them at the bedside, putting them at the places where people can use those guidelines. It might be because I helped write an appendix for this report. I co-authored this with an emergency medicine researcher, as well as a military trauma surgeon. Same thing, we had to work together. I don't know the military, he didn't really know the civilian. We worked together on the military trauma care's learning healthcare system and how it could be translated over into the civilian side and using data to make decisions for patient care. Of course, I wrote this part here. It talks about how important the East guidelines are. There's these East guidelines, et cetera, but we talk about some other guidelines I'll talk about as well. But this is important, that we should be using guidelines to standardize care, whether in the military or civilian. And this is a national book for every trauma surgeon to be reading and to know about. So how many are out there? There's about 75 guidelines out there. They're high quality papers. They're mostly published in the Journal of Trauma, but there's some published in some other journals as well. They get routinely cited many times. The mean number of citations is 50. So each of these papers has about 50 citations. There's 11 of them that have over 100 citations. They're very well cited. The number of citations is continually rising, and this is old data now. This is only until about 2019, and the numbers keep going up. These are the 2 papers with the highest number of citations. This one is about venous thromboembolism prevention. It's a little old. It has some information that's really good. There's much better data. I can tell you all about that another time. And then another one about critical care and transfusion. Getting 300 or 400 citations. Lots of impact these papers are making. It's also a great opportunity to help teach and mentor residents and fellows. I personally counted about 9 residents or fellows that have co-authored guidelines, either with me or that I got hooked up into this committee. And it's a great opportunity if people wanted to get involved in East, please join. Like I said, we have international members. Come to our meeting. We just had our meeting in Florida. It's a great meeting, but it's a great opportunity for us to teach the next generation. We collaborate with many other societies. So some of these are the Pediatric Trauma Society, the Trauma Anesthesiology Society. We have one now with the Orthopedic Trauma Association, the AAST, which is the American Association for the Surgery of Trauma, Society of Critical Care Medicine. All these groups, we have co-authored guidelines with all those groups. I've gotten to talk about guidelines all around the world, as have many of my partners who've written on guidelines. You see Society of Trauma Nurses. I went and presented at that meeting as we were talking about collaboration with nurses. I went and presented at that meeting about guidelines. all these different places, both in the US and abroad. So I know I keep saying East, I'm wearing an East shirt, etc. I have East socks on, I showed Dr. Ficky, but there's other places for guidelines. East is not the only place that has guidelines. So where else can you find guidelines? So I mentioned this already, the American College of Surgeons Trauma Quality Improvement Program, the TQIP program. This is an older list of how many guidelines they have. I think they have more now, but this is a great place to go. Many, if not all of these resources are freely available that you can go get tomorrow for free online. So the American College of Surgeons has these great guidelines. The Western Trauma, they call their things algorithms. As you can see, and I showed one earlier, or a couple earlier today, it's a flow diagram of what you should do based on this. It's not quite as evidence-based, but they have some references there, but it's expert opinion on how would you take care of a patient with lower extremity trauma or penetrating abdominal trauma or whatever that is. So you can go to their website and find that information there. There's military trauma guidelines. So some of these are very applicable and move directly into the civilian sphere. Airway management, pelvic fracture care, thoracic injury. Those things you could use at your civilian trauma center today. There are other guidelines that Drs. Ficky and Osgood needed that I don't need, and hopefully I won't be doing. Cranial procedures by non-neurosurgeons in a deployed setting. So hopefully I don't need to do a craniotomy, but in the military, that's an important guideline. Or dismounted complex blast injury. What is that? That's people walking along and walk over an IED and the IED blows up and blows their legs, their pelvis, all these other things. We don't see that in the civilian side usually, but it's important for them. And the last one, we actually ended up talking about it at lunch today, unexploded ordnance. So unexploded ordnance is someone gets shot with a rocket propelled grenade. There's a giant grenade. It's within their body cavity. It hasn't exploded, but it might explode soon, and someone has to go take it out. So there's a guideline on how you do that. I talked to a military surgeon recently who said they were training on how to do that. They put on the big bomb suit that I've seen on TV and never worn, and it's very heavy, it's hot, it's uncomfortable, everything is covered. And the person explaining it said, you're gonna be fine if this thing explodes. Now their hands are out because they're operating. So except for your hands, everything is fine. The surgeon wasn't very happy with that. But there's guidelines on how this happens. I don't need that one. But this is another place to look for important guidelines. The WHO, World Health Organization, certainly has guidelines for essential trauma care. This is something that around the world, when I go and talk, people know about these guidelines. The Pediatric Trauma Society, they're a young group. They're less than 10 years old. They've started working on guidelines. They started with us, and now they're working on their own. So there's lots of other places to get guidelines. Make sure you're picking somewhere that's well respected, and I just gave you a list of some of them. So I'm going to transition to my call to action. So this is what I want you all to do. And I asked the audience of 1,000 people to do this. I said, please help us disseminate and spread the word about these guidelines. I want you to do it locally at your institution, but I also gave some examples of how you do this at a county, state, regional, national, or global level. Okay, so the first thing to do, east.org, very easy. All of the things are free. If you pull it up on your phone, it gives you the choice of what you want to look for. You can search by category. You can look at each topic, etc. So that's how you find them. It's super nice on your phone. There you go. The Journal of Trauma has made these all freely accessible to anybody who wants to read them. Even if you don't have a subscription to the journal, you can go to the East website and read these guidelines. How might you want to do this at your institution? So the first is presentations. So a teaching conference. If you're doing a teaching conference on spine trauma, bring the East guideline. If you're doing a teaching conference on liver trauma, bring the East guideline. It's a really good way, as an example, journal club, morbidity and mortality conference, grand rounds. There's these formalized presentations with slides, et cetera. That's one option. The other option is word of mouth or bedside teaching. So I'm in the emergency department and I have, lots of different people. So I have my colleagues, my partners, I have residents, fellows, students, nurses, PAs, nurse practitioners from all different specialties. surgery, anesthesia, emergency medicine, critical care, orthopedics. I talk about them all the time. Every single time I'm on trauma call, there's some patient where we're talking about something. We had a patient with a gunshot wound to the leg, and I was talking to the resident, and I said, "Oh, have you read the East guideline?" And one of the residents was like, "Oh my God, not again." The senior resident like knew that, but the intern was like, "No, tell me." And then they went and read it, and they learned a lot of the stuff I explained this morning. So use it both formally and informally at your hospital. This is an example of one of our residents a few years ago who used one of the East guidelines up here, and he put it up here on the slide, and he was giving it a combined conference that we do with the trauma team and emergency medicine. And then, of course, I got teased. He was teasing. He wasn't very nice to me. It's okay, I have thick skin. And I said on Twitter, if you're going to get mocked in front of a giant audience from Hopkins Medicine and Hopkins Emergency Medicine and Surgery, at least let it be for using evidence-based medicine. So that was Bobby. You can also disseminate these more formally. Don't reinvent the wheel. If you want to come up with a spine clearance protocol for your hospital, don't start from scratch and start with a blank page. Start with the East guideline. Don't reinvent the wheel. You can adapt an East guideline, a Western trauma algorithm, a TQIP protocol, whatever it is. You might have to modify it a little bit. You could just take it right off the shelf and use it at your hospital. That's one option. Or you can modify it a little bit, but most of it's there. Most of it's there for you to use. So please don't start from scratch. So that's a way to do it more formally at your institution. Here's an example. There's other places. This is guideline implementation. How do you actually make a guideline work? This is from Australia. And they talk about, you need leadership to say what we're going to do. And then you've got someone who's going to actually make the work happen. You pull together a multidisciplinary forum, and that is doctors plus nurses, and it's either trauma plus emergency medicine or ortho or neuro, or whoever they are. You get them all together. You come up with a local policy or a local protocol, and then you ask the individual to do that as well. I went to a talk by a surgeon I know from Washington, D.C., and he gave this talk. He said, East guidelines to standardize care at my hospital. And so I asked him, I said, can I have your talk? He's like, sure. So I have a few slides here just to get an idea. Teach a man to fish. Okay, so what does this really mean? Everyone, you have to teach them what they need to know about the guideline. It's not just go read the guideline. Here's the guideline, here's the steps. These are the important pieces to do. You're going to hopefully win people over, even if it's not their opinion now. They might read the guideline and, wow, I didn't know that literature. I didn't realize that these 20 experts have agreed on these recommendations. So you start with that. So how do you do it? Pick problems that exist. If you don't see a lot of penetrating trauma at your place, don't start with penetrating lower extremity trauma, right? If you see a lot of blunt trauma, start with something, I'll call it easy, something common, something straightforward. Pick something that you need to do in either trauma plus emergency medicine. Try not to pick spine is actually hard. Emergency medicine, orthopedics, neurosurgery, neuroradiology, all these other things, really hard. So pick something a little bit easy. Be honest. This says, get rid of your own prejudice. It's hard when everybody else says, well, I'll go with the guideline, and you think, well, I don't really believe the guideline. At some point, you got to go with the flow and you got to do with it. So, and then spread the word, discuss it all the time. His slide is very similar to mine. Morning report. So we have a trauma morning report. It's a very common way that we deal with trauma patients. We talk about every single patient that was a trauma patient from the previous 24 hours. Bring it up at that morning report. M&M, he does the same things. Where are they? Email the PDFs, all these other pieces. Tell everybody. Here's this list. I know you can't read it. That's okay. You're going to go to the website and you're going to pick the ones you want to look at. Here's a list. Maybe these are some ideas of what you might have. And you're like, oh, we've really had a problem with geriatric trauma, or we're not using TXA as much as we think we should. Pick one or two to get started with. There's other places that have guidelines too, and not just the national guidelines that have been written and published in journals. These are two examples. One is from Vanderbilt University. The other is University of Pennsylvania. You can go to their website. You can look at their hospital protocols and their hospital guidelines for different things. What does their massive transfusion protocol look like? I wonder what they do for feeding in the ICU. I wonder what they do for DVT, venous thromboembolism prophylaxis. You can go and look at other people's things. So then I got 5 minutes and I got to cover, is your guideline working? And this is really, really important, right? You can do all this work. I'll come and talk to you. I'll tell you all about it. And I have no idea when you leave that door if you're ever going to do anything about it, right? Some of you might look at the guidelines. Some of you might bring it to your hospital. Some of you might implement one. Some of you might do nothing. I have no idea. So how do you know if your guideline's working? So this is where I'll put on my hat, quality and safety. And we're going to pivot a little bit to venous thromboembolism prevention, but you'll see why it's important. So we're going to look at the power of analytics. We're going to use the computerized order entry system. We have Epic, other people have other places. And we're going to see how we're doing with implementing best practice. So we've got a decision support tool. It's built within Epic. It tells everybody what to do for venous thromboembolism prevention in trauma patients. Okay, here it is. If you look at before we had it versus after, our VTE prophylaxis appropriateness was about 70%. It went up to way up here, 85%. So we're doing well, okay? VTE moves in the right direction, although not statistically significant. And we were mostly able to decrease, we definitely decreased, and we almost eliminated preventable harm. So we're doing better. So we have a guideline, okay? Are people using it? I don't know. So we said, we're gonna give feedback to the trauma surgeons. So we're gonna give feedback to the trauma surgeons about whether their patients are getting appropriate care. So each bar here is one surgeon. The trauma attending physicians are these dark bars. And you see we're all about the same, statistically no different. Each of these other bars is a resident physician trainee. 7 residents never, for the whole course of the entire year, gave appropriate DVT prophylaxis. 42 residents gave appropriate DVT prophylaxis every single time throughout the course of the year. So now we know, and we can figure out, what did Dr. Ficky do? What did Dr. Sahi do on an individual person level? Okay. It turns out you don't have to talk to the attendings. They're just a random mix based on the residents that are on your team. The residents are the target. So we give feedback to the residents. So what does that look like? So we decided to give them feedback. Each resident is one of these lines. You know your number, you know your number 1, your number 2, your number 3, and you would get feedback for the previous month. How did you do on following the guideline that the computer helps you do? And you would find out, oh, Dr. Ficky's at the bottom, he's red. Dr. Sahidi's yellow, etc. Right? And you would know where you are. Overall, we were 87%. 1 month later, we went to 93. 1 month after that, we went to 96. Give feedback. Because you know what you'd find out? Dr. Ficky would be like, am I really that bad? Am I really worse than my peers? I've never been the worst ever, ever. I don't want to be the worst. So everyone does better. It really makes a difference. Okay. And here's what it looks like over the course of an entire 18 months. This is before. These are all aggregated data. We were in the 85 to 90%, not too bad, but we improved dramatically in 1 month. In 2 months, we were mostly green. This is the July effect. The July effect is every July we have new residents that start, okay? And we didn't teach them well about the protocol. It's our fault, right? It's not their fault. We didn't teach them. So they did poorly. And then once we gave them feedback, they went up to the green. So it makes a difference. This is how you can modify this. And you can do this by pulling data from your registry. You can do it by hand. You could do it manually, but using data to bring it back to individual clinicians about, are you following the data? Are you using the guideline as we put it out there? We now have dashboards. I can pull this up by floor, by nurse, by unit, by service, for all these different things about venous thromboembolism prophylaxis. And using that data, working with your people, Epic or whatever your system is, to get that data back, then you can find out, are people really using the guideline that you think they are? So with that, I'm going to remind you and put up the links here. If you want to hear more information about the EAST guidelines, there it is, east.org, very easy place to find them. Thank you.